Welcome back to this video on eating disorders, part 2. We're going to start out talking about binge eating disorders. And binge eating is not accompanied by those compensatory behaviors that we talked about in the last video on eating disorders, such as using laxatives, using diuretics, vomiting, excessive exercise. That's not happening with this type of disorder. A binge eating disorder, the person is going to isolate themselves in order to be able to eat those large quantities of food. So again, very similar to bulimia, our person is by themselves, probably sitting in the kitchen and eating tremendous quantities of food, 3,000 or more calories at one setting. They use food to help to reduce their stress. It gives them that feeling of control. It gives them that feeling of well-being while they're eating the food. They are kind of getting this head rush. One of the other things we didn't talk about in the last video is how fast someone eats. Of course, in order to eat this tremendous quantity of food, you're going to have to pretty much stuff that food down your face, because you need to, in order for this to be a kind of binge eating, you need to be able to eat all this food within a 2-hour period of time. That's a lot of food, and so you're really eating fast. One of the things we found scientifically is the faster someone eats, the more serotonin they are releasing, and the better it makes your brain tell you feel. And one of the theories behind anorexia, bulimia, this binge eating disorder, is that the person doesn't make as much serotonin naturally. And so they need that serotonin boost. They want that boost to feel more powerful, to feel better. And of course, we're not usually binging on broccoli and carrots. We're typically binging on junk food. And we eat without any regard to how much we feel like eating. So you don't have to be hungry to eat. You just need that emotional response from eating. About 4 million people in the United States have this disorder. About 40% are male. There are more cases of binge eating disorder than anorexia or bulimia. It's most common among severely obese individuals. Now, again, like I said, there's that genetic predisposition for people who potentially aren't making enough serotonin. So the disorder arises when a person is stressed. So they have some kind of emotional stress that's going on, and so they want to eat. Now, in psychology, one of the things you learn about people who have this binge eating disorder, for females especially, is that there may be an emotional incident that's occurred in their lives, let's say like rape, where the individual now wants to make themselves unlovable, unattractive, and so they start this kind of binge eating disorder in order to keep others away from them. So the diagnostic criteria for this disorder is they have recurrent binge eating. They're eating a lot of food in that short period of time, that 2 hours we talked about. They're experiencing a loss of control over eating during the binges. That means once they get started, they really feel like they cannot stop. And the episodes of binge eating are associated with at least 3 of the following: rapid rate of eating, continuing to eat well beyond feeling full, overeating in the absence of hunger, eating alone to avoid embarrassment, and feelings of self-disgust, depression, guilt after that overeating episode. So they also have to have extreme distress about binge eating. It doesn't make them feel good. They don't want to do this, but they feel like they're an addict. They can't stop. And the binges occur at least one time per week for 3 months, and the behaviors are distinct from bulimia and from anorexia nervosa. The physical effects of binge eating, one of the things, of course, is if somebody keeps eating all of these calories, they're going to become obese. So about 70% of the people with this disorder are obese, and that, of course, leads to hypertension, of course, junk food, lots of sugar, lots of sodium intake, and elevated cholesterol, cardiovascular disease from all of this, type 2 diabetes from all of this obesity. So the primary goal is to decrease and eliminate the episodes of binge eating. And of course, in order to do this, you really have to do therapy with these people. And of course, the secondary goal, get them into the correct body weight. And we want to get rid of the obesity and all the conditions that come with obesity. And of course, work on that psychological issue that's going on that triggers this binge eating. So about 30% of participants in weight control programs have binge eating disorders. And many have difficulties identifying their emotional needs. Okay, they can't really express their emotions. Maybe these are people who everyone else expects them to be the caretaker, and they don't know how to take care of themselves because they've been so busy taking care of everybody else. Or maybe this is the person who was not allowed to express emotions in their family, and so they're not able to do any of this. And so cognitive behavioral therapy, again, is an excellent therapy to use for binge eating. And we have one-on-one sessions. Group therapy is also very important because these people need to learn how to take care of themselves, but a lot of that self-care is going to be while interacting with other people, especially people who are close to them. And so they're going to need that group therapy in order to do this. Overeaters Anonymous is one of those types of self-help groups. Nutritional therapy, we're going to learn to eat in response to hunger and not outward factors. Nothing is going to trigger me emotionally that's going to make me want to eat. I'm going to eat because I'm hungry and for no other reason. And keeping a journal is very important in all of this, and they need to understand not only what the emotions are that's going on that triggers their hunger, but also they're going to journal about physical hunger, because a lot of these people have eaten in a way that they never even feel hungry. They don't even know what physical hunger really feels like. And they have to learn then to respond to the fullness at each meal and to slow down, to eat the meal, to know when to stop eating the meal. Weight loss diets are not going to cut it for these people. They need to just eat appropriately and definitely not get into any of these deprivation cycles, because that could trigger the binge eating. And of course, the long-term goal is to learn how to take care of yourself psychologically, emotionally, and to eat food in moderation. Now, in the meantime, pharmacological therapy has been approved for binge eating, and there are a couple different types of medications. Vyvanse, is a stimulant used to treat people who have ADHD, but seems to help with people who have binge eating issues. There's also some antidepressants, anti-seizure medications like Orlistat that are able to reduce the depression and the different emotional triggers that cause people to binge eat. And so this, of course, can assist with weight loss. And what it does is it's not something that typically you're going to have your patient on for long term. You want this medication to help your patient to get started down the road of health and healthy eating. And questions about eating patterns can also help to figure out what kind of treatment your patient is going to need. So another type of potential food disorder is called pica. And pica is where people eat this non-nutritive, even non-food substances for over a period of at least 1 month. And that could be things like ice or chalk, wood, dirt, clay. This is pica. Now, pica sometimes has physiological reasons why people eat it, and then other times it can have serious health consequences. Like, for instance, eating wood is not a good thing, but some people will eat tremendous amounts of ice, and we're not really sure why, but when you see somebody really chewing on ice, and I mean, the whole idea is not necessarily the ice, but it's the chewing part of chewing on ice that tells you the person is iron deficient. Or, for instance, somebody eating chalk, it shows you that the person is calcium deficient. Or individuals who will start to eat dirt are very typically magnesium and various different mineral deficient. And so some of this pica has a nutritional reason why the person is eating it. Other times it's a psychological reason. So one of the other problems is you don't want your patient to be eating dirt because there can be microbes in it and infections can occur. Different toxins can be present in this non-food material. It can cause gastrointestinal blockages. And then, of course, we have to look at what kind of nutrient deficiencies does this person have, and we need to replenish those deficiencies, and hopefully that would be enough to stop the pica. If not, we need to figure out what the other problems are. Is this autism? Is it obsessive compulsive disorder? Is it something totally different? And to treat those mental disorders. So other specified feeding or eating disorders, there's something called sub-threshold eating disorders. This is kind of an atypical anorexia. It meets most of the criteria for anorexia, but the weight is still within the normal range. Bulimia nervosa or binge eating disorder episodes occur less than once per week. And then you have what's called a purging disorder. And this is repeated purges to promote weight loss, but they don't have the binge eating going on. And then body dissatisfaction, anxiety, depression are all present in this. The effects are the same as those with bulimia, except that they don't do the binging. So these are two other types of eating disorders. There's another one called night eating syndrome. And eating more than 25% of your calories at nighttime. So this is late at night after your evening meal, and you're eating it so late at night and you're eating so much of it, you don't even feel hungry in the morning. And these people who have this night eating syndrome, they need to eat to be able to fall asleep. And they're waking up at nighttime and they're eating. They're eating, of course, they don't like this because this just doesn't seem right. And so there's a lot of guilt and shame that go along with this. So this is not only an eating disorder, but it's also a sleep disorder. And so there may be some neurotransmitter interactions that are going on where the eating is increasing serotonin or norepinephrine, and those neurotransmitters are needed for these individuals to be able to even go to sleep. So, of course, depression can happen at nighttime, especially if these neurotransmitter levels are low. There's also something called the female athlete triad. And the people that are at risk for this, of course, are female athletes. And usually they're in endurance sports. And these endurance sports are appearance-based. So think about, for instance, a gymnast. Okay? 15% of these types of females are going to be swimmers, 62% gymnasts, 32% varsity athletes. The triad would include low energy availability, lack of a menstrual period, so they have amenorrhea, and osteoporosis due to loss of estrogen. So what's happening with these female athletes is they're not eating enough food. And because they're not eating enough food, then they have this triad of difficulties in this loss of energy. They don't have enough fat on their body, so they don't have menstrual cycles. They can't produce the steroid hormones, so they have osteoporosis. Their bone density is terrible. You have this young girl who's 15 years old, and she has the bone density of a 60-year-old. So this is a really, really bad thing. And the bone loss can be so bad that their bones will break a lot and early in life. And you see this especially with gymnasts, okay? Because they're supposed to be tiny and they're supposed to be short. And they are given very low calorie diets in order to perform. Now, treatment for this, okay, so what happens is you have this little girl who is trained into believing that in order to win at the Olympics, to become this great star, you have to starve yourself and you have to work hard. So it's very similar to having anorexia, but they have this preoccupation with it because of their sport. So you have to, first of all, once they figure out what's going on, you have to change their perception and their preoccupation with their food, their weight, their body fat, and give them healthy meals. And then help them to achieve the appropriate weight for their height. But hopefully, if you catch it early enough, you'll be able to give them the appropriate height. Because again, a lot of these girls are put on these low-calorie diets very early in life, and so they're very short. This, if they have enough calories, will help them to have a menstrual cycle, and then you have to lower the intensity of training, which is why it's very difficult for these girls, because they know, and even boys to some extent, this is happening too as well. They know that this training and the amount of training is necessary to compete. There's also something called muscle dysmorphia, and this is kind of the reverse of anorexia. These men mainly, but some women, think they're too thin, and so they are constantly in the gym, they're dieting, they have these massive regimens of protein powders and things to eat so that they can lift weights more, build more muscle. And then, of course, the problem is you can only build as much muscle as your genetics allows you to grow. And so if I can't build all the muscle I want because of my personal genetics, then what else do I do? Well, I start shooting up with anabolic steroids. And anabolic steroids will help me to grow more muscle. So this muscle dysmorphia can also create other eating disorders such as anorexia or bulimia. And one of the things that happens with people who then have these eating disorders, they may avoid social contact, which is all part of it. And now they are embarrassed and they feel guilty and they don't want to be around people because now I'm too thin because I've developed this eating disorder. Diabulimia This can be practiced mainly, you see, with adolescents, and these adolescents have to have diabetes. So this one is really quite scary in my opinion. So we have two types of diabetes, type 1 and type 2. So in type 1 diabetes, 1 in 3 teenagers admit to intentionally skipping doses of insulin in order to induce weight loss. Now, I can make you fat. All I need to do is inject you with insulin. If I inject you with insulin, I can make you fat. Because what insulin does is it prevents the breakdown of fat in the body. And I cannot use fat as a fuel source, and so instead I just store fat. I just keep packing on the pounds of fat. So these people with type 1 diabetes, they don't make insulin normally in their pancreas, so they have to inject themselves with insulin. And so in order to be thin, they just stop doing that. They skip a dose. 1 in 5 teens uses overdoses of insulin to compensate for episodes of binge eating. So basically what that means is I am going to eat whatever I want. Cake, ice cream, pizza, whatever, and I'll just give myself extra amounts of insulin and it'll take care of all of the extra sugars that are in my system. However, it doesn't work that way, and instead they're going to create bigger problems with their cardiovascular and their renal system by doing this. This could also lead to dangerously low levels of blood sugar. And the consequences, like I said, include kidney damage, eye damage, diabetic coma, even death. Type 2 diabetes, up to 25% of teens show signs of binge eating. So very similar to what we just talked about with type 1 diabetes. They're going to eat whatever they want and just give themselves a bigger dose of insulin and it'll be okay. Orthorexia. This is what we're considering an emerging condition. And this is where people are obsessed with eating what they think is healthy. So it's not really classified in the DSM as an eating disorder, but it certainly can cause physiological problems to a person. That's because these individuals have very strict rules about what kind of food they can and cannot eat. And they're very excessive. And so it can be certain things like I'm only going to eat sugar-free, or I'm only going to eat organic, or I'm only going to eat non-fat, or whatever it may be. They have this big list of what they do and do not permit themselves to eat. And one of the issues is when you do something like that, you become so freaked out about food that you have a tendency not to eat because you don't know what to eat. What do I do if everything isn't sugar-free? What do I do? And so they have a tendency to become more anorexic. And one of the issues is they start to have this drive for perfection and for purity, and it's not really a drive to be thin. It's in their mind, this drive to be healthy, but can you see again, this is all a control issue. There's not this middle ground of eating healthy, being healthy, accepting yourself, and yourself being this happy person. So this is extreme dietary perfectionism, okay? And it could be related to obsessive compulsive disorder. Prevention of eating disorders. So discourage restrictive dieting and meal skipping. Provide information about normal changes during puberty. For instance, it's okay for a woman to be jiggly. That's just the way it is. That's how females are. Correct misconceptions about nutrition, healthy body weight, and approaches to weight loss. Carefully phrase weight recommendations and comments. All of these are very important, especially even before puberty, to start teaching children to accept who they are and to feed these children healthy meals. And don't overemphasize weight on a scale because, for instance, a pound of fat and a pound of muscle doesn't look the same, okay? And so a person who is building muscle may be stepping on a scale and all of a sudden they're weighing more, but that is more healthy to actually weigh more as far as being able to have less fat on the body, more muscle, because that muscle is going to help you to be more healthy. It's going to provide more energy for the individual. And encourage normal expression of disruptive emotions. It's okay to be afraid. It's okay to be sad. It's okay to have the feelings that we're feeling. We don't have to stuff those feelings down. We don't have to stuff food in our mouth to try to make us feel better. Instead, we should be able to express the emotions that we're feeling. Encourage children to eat only when hungry and to increase self-acceptance. Not everybody has the same body style. Not everybody wants to be this skinny runway model who is so skinny they can't run a mile. Enhance tolerance for diversity in body shape and in body weight. And build respectful environments and supportive relationships instead of negative, bad social media things. And then emphasize that thinness not necessarily associated with better athletic performance. So athletes don't need to be stick thin. As a matter of fact, they need to have plenty of muscle in order to perform. Have you ever seen a stick thin football player? Obviously, they know that muscle is necessary for them to be able to perform, and it's the same thing for female athletes. Support programs for eating disorders should be early on, for instance, in high schools and colleges and in the media, in order to help people to change their perception of what is healthy and what is beautiful. So going back to that original, what would you do for your college roommate? One of the things that is recommended is to get prepared before you confront your roommate. Know what is needed. Find out what information and resources are available on your campus so that you can share that with her. And recognize that you're not going to cure her disorder. She needs professional help. Be supportive and patient as she deals with the problems that she has, and listen and offer to go with her to seek care. See you next time.